My name is Peter Schneider, and I'm really honored to present this webinar that we're going to have over this next 55, 60 minutes. We have two real stars in the vascular community who have cases to show, and we're going to really talk about the use of serration, that is, Serenator or serration remodeling therapy, in the context of AV fistula maintenance. And we all know this is all of us who do that kind of work know that there are many recurrent issues that happen with these patients. This is a lifeline for these patients. So anything that we can do to extend patency or to diminish the need for reinterventions is well worth the effort. So, and in that context, I want to introduce, like I said, two rising stars. Maybe they're not rising anymore. Maybe they are stars. But anyways, Atish Chopra is a fellow of the American College of Surgeons, practices in Dallas at TCU, and was the first in the US to use the 8 millimeter Serenator, which was launched not too long ago, within this past year. Also, Dr. Yana Etkin, who's with the Northwell system, which is in New York, and she's the director of both the Vascular Fellowship and for fellows and for residents, and has been well, I would say, has many accolades as a teacher in this area. Of course, I've heard her lectures, and she does an excellent job. So, um, with with that, let me just before we dig into the seminar here and the cases that you have to show, let me just ask a few questions about your practice and about how that works. So maybe I'll start with you, Yana. For in your practice, you probably do. I'm just going to guess that you do fistula creation, fistula maintenance, maybe also some declotting. Give the audience a little bit of sense of what your practice is like and who sends you the cases and what kinds of cases they are.
Thank you for this introduction, Peter. So my practice in New York City, I do a little bit of everything, but dialysis access is probably about 25% or so of my practice. Dialysis access found me. I wasn't looking for it. It was just a huge need when I started my practice 11 years ago. And all I knew realistically is how to create dialysis access. But then I realized that I didn't want to just create it and give it away for intervention. So I basically learned on my own how to do maturations, reinterventions, and it sort of grew and grew and became more and more complex. I do my own. I didn't start doing thrombectomies, but now I do all my own thrombectomies. And as you all know, as this dialysis practice grows, you get more and more and more complex patients. So I start getting a lot of like central stenosis and occlusion patients lately. So it just becomes more and more complex. So for me, it's not just creation, it's sort of well-rounded dialysis access practice in addition to everything else I do, but I try to kind of provide full gamut of interventions for dialysis access.
Okay, interesting. That sounds great. How about for you, Atish? How does it work in your group?
Yeah, thanks, Peter. I'm in Fort Worth, and so I have a pretty varied practice. I practice at a couple of level one centers as well as a couple of level three centers in ASC as well as an OBL. So kind of a broad spectrum a practice, and uh, similar to you, Yana, dialysis access kind of crept up on me more and more, and it's been increasing. So I have to sort of limit it at times. But yeah, it's probably about 35% of my practice. And I find it challenging and satisfying and everything that comes with it, both with the patients as well as with the interventions. And you see how much this really takes over some of these patients' lives. You know, they're really living at the dialysis centers, if not at the dialysis centers, in and out of hospitals for interventions, for maintenance, and so coming from that, I've really developed a passion for trying to get these patients out and living whatever life they can and getting close to a resemblance of their prior life as they can. And so it's very rewarding when we can do that. And So initially, similarly, I would start off with creations, and then some maintenance as well. Now, in the DFW area, we do have a strong interventional nephrology presence, and they do maintain a lot of access. And so a lot of my maintenance access is skewed towards some of the more complex patients, patients where they haven't had as much success, in an outpatient setting. And I really try to work with them to try to prevent stents and other procedures that might compromise future access options for these patients. And thankfully, my colleagues have been very strong in supporting me in that endeavor, and they are very passionate to do the same. So it's been very rewarding. But yeah, it's definitely been growing practice in that regard.
Yeah, yeah. Well, that makes sense, and I mean, it seems to be a growing need, especially with diabetes being so prevalent now in the community, patients living longer, and of course, renal insufficiency progressing to failure seems to be on the rise. And of course, then we are very often the frontline team to make sure that that can still happen for the patient. So let me just ask you also about reinterventions. Maybe back to Yana, do you guys do any surveillance, or do you uh, check flow rates with the dialysis units, or how do you know if maintenance, obviously it's really great to do it before the graft goes down or the fistula goes down, but there's just different ways of managing that. How does it work in your practice?
So I do not believe in routine surveillance with like ultrasounds, for example, because I think the data does not support it. I try to practice data-driven medicine. I do a lot of dialysis centers know where to call. My patients know where to call. Don't get me wrong, they get sent to a lot of other places, but some of my patients are very loyal and they're like, oh, they're sending me for cleaning. This doesn't make sense. I'm gonna come back to you. Do I actually need cleaning? I right away call dialysis centers, like, is there issues on dialysis? And if they say, no, no, it's just routine, I'm like, there's no such thing. So I do never do routine cleanings. I don't do routine ultrasounds to surveil things unless there's something in physical exam, like aneurysmal fistula, prolonged bleeding, right? Flow, the pressures on dialysis are off, low flow, things like that. But I do not routinely surveil or routinely intervene. It's all driven by issues on dialysis or issues on like physical exam, arm swelling, things like that. And when it comes to interventions, I think the whole thing is, like Atish mentioned, these people go through so much. So I try to think, what is the intervention that's going to last the longest? Because we know we're going to reintervene, but can we get more time out of our intervention? And we have to also think of cost in today's environment, right? And which the intervention that is reasonably cost is reasonable, but gonna get the longest, period of no intervention. I mean, I don't think people should intervene every month. Like if you're intervening every month in the fistula, you got to think this is not right. This something else needs to be done. So that's sort of my algorithm.
Yeah, makes sense. Makes sense. And Atish, how about in your practice, where do you see serration remodeling therapy? Where do you see this concept or idea come in? Do you use it routinely? Do you use it on only the tough cases or the recurrent recurrences? Or how should people think about it in their algorithm? I know you're going to show some cases, so we'll get some more ideas, but just on the surface of it, how would you describe?
Yeah, I think it's sort of developed, a little bit more as a feel kind of situation. If I look at a lesion, and you'll see some of my examples, you start seeing the ones that probably are not going to have a durable result with just straightforward POBA. You can just see they're very tight, very fibrotic, resistant. And so for those lesions, I kind of jump the gun and go straight to serration therapy. There's no point in trying to save a balloon when you're going to use another balloon and then going to get to the same point anyway. And so that's kind of evolved over time. But I do try to be conscientious if I feel like the patient's had multiple interventions and they're going to need, or maybe benefit from drug-coated balloon angioplasty, try to pick and choose. Obviously, you want to make sure you get the maximal luminal gain. And so if I can achieve that with POBA and drug coated, great. But otherwise, if I know that it's going to be resistant or it looks like it's going to be resistant, I jump to serration therapy to try to prolong it. initially, like I said, my practice has kind of evolved because of the interventional nephrology presence. So I do get a lot of sort of complex cases, and because of that, these lesions tend to be more resistant. So my use has definitely gone up. My previous algorithm had involved more scoring balloons and then plus or minus drug-coated technology as well. I've kind of backed off of that. I use those pretty selectively now for a variety of reasons, including, just I think the trauma that it does to the vein. Every once in a while, you'll get a rupture of the vein or of the balloon. And so I do think while they're effective, there is a perforation rate with it, and studies range from 1 to 4%. And so what I like about the serration technology in the setting is I find it incredibly safe. I've never had a vein, knock wood, perforate from it, a fistula, ever rupture or anything like that. And so I think it's very controlled and very safe in that regard.
Okay, yeah, good to know. All right, I'm going to show a couple of slides just to kind of set the stage a little bit, and then let's do the fun thing, which is look at your cases, which is always fun to talk about. So this concept of serration remodeling therapy, it really relies upon a couple of different ideas sort of coming together. The serrations that are produced by the external devices or external strips on the balloon itself really act as a relief plane. So this is a place where the balloon energy can be directed, and the so-called micro fissures. And it really allows the artery to, or the vein in this case, to open at a pressure that typically would be lower than would be expected. And by incising down to the, through the internal elastic lamina, you're creating a situation where the artery is allowed to open rather than just stretch. You're actually remodeling the artery so it allows it to open. And we've seen great results from it in terms of reduced reinterventions, reduced freedom or improved freedom from CDTLR, et cetera, both in the dialysis situation and in the situation of iliacs, PEMPOPs, and BTK devices. And here's just an example. So this is an OCT from the Prelude BTK study. So this is a tibial vessel. This OCT, kind of demonstrates the location of the serrations, and then you can also see with IVUS. Of course, the OCT shows typically a little more detail, a little bit more refinement in terms of the imaging capability, but you can also see them on IVUS. And then in terms of results, like I said, so here's from the combined Prelude studies, freedom from CDTLR at 6 months of 97.7, reduction in recoil, and minimizing dissection. The recoil one is quite interesting because I think in particular tibials are highly susceptible, but I think also dialysis venous outflow is highly susceptible to recoil. And the recoil study that we did compared plain balloon versus serration remodeling therapy in the tibial vessels, and it showed a dramatic reduction in recoil. And of course, that was a study where um, the after the completion angio, the patient stayed on the table for 15 minutes, and then the repeat angiogram was done. So it was not an easy study to conduct, primarily because just the change in the workflow and the relative inconvenience to the patient and the team. But nevertheless, we were able to do that study and kind of repeat the study that was done many years ago by Bauman that showed this dramatic challenge with recoil in the tibial vessels, and that was dramatically reduced. Now, we haven't done that in the dialysis population, but it might be fun to think about at some point, this issue of how can recoil be mitigated. My own clinical impressions in the dialysis arena is that actually you do get a very good finished result after serration remodeling. So the BTK I mentioned, many people are using this as their definitive therapy. Of course, with BTK, a lot of times your choices are plain balloon or atherectomy followed by plain balloon. And so this it gives an opportunity for a treatment like this to become definitive therapy. In the above the knee, so far, and again, there have been tens of thousands of cases done already with serration remodeling, but in the above the knee, 70% of the cases in the data that we're keeping occur prior to DCB. So this is typically as a vessel prep situation. In the AV fistula, this idea about using it as definitive therapy is quite reasonable. I think some people probably also, not the majority, but some people also use it in conjunction with DCB to prepare the way. And there's probably the occasional stent in the very challenging patient. But for now, I mean, I think what you said before about stent avoidance is right. I mean, that's basically the last option that you typically entertain. Nevertheless, so serration remodeling therapy, we've seen now over a period of years in a variety of vascular beds, patient-driven outcomes, quite a bit of versatility with different lesion morphologies. Of course, the dialysis outflow lesions being quite different from, say, a BTK lesion with medial calcification or an above the knee calcified intimal medial type lesion. But also, and as Atish and Yana both highlighted so far, with safety and efficacy. So I'm going to stop sharing, and I'm thinking maybe Yana, you could show a couple of your cases, unless either of you have any questions about anything I just said. I know questions are coming into the chat, and we'll get to those, but
Yeah, just to mention, Peter, as you mentioned, I think the two important things that you highlighted is that the balloon allows you for lower pressure, and I think we know that in this space of dialysis access, the underlying etiology of stenosis is intimal hyperplasia. It's not atherosclerosis, but the intimal hyperplasia happens because of continuous injury and uremia and the needle insertions. And then we know that high pressure balloons create more injuries. So you're really going to incite more intimal hyperplasia down the line. So using lower pressure, really what interests me in this technology, because I know it creates less injury. So I'm hoping that would means less reinterventions. And then we always see recoil. Like this is the place where the veins always recoil. I have several cases before I use this technology where you do angioplasty of a fistula, looks great. 5 minutes later, at the end of the case, again, the lesion does not look great. And then you're facing it like, am I gonna stent this? Am I gonna use, I'm not a big DCB user because I think the cost is kind of prohibitive compared to what the results of the studies are, right? There's really no good conclusive study that says it actually helps down the line, and the cost is a lot, and while, these balloons also not cheap, but I'm hoping that's because it's a different technology, it will actually show down the line that there's less recurrence because there's less pressure that we're using. And we're remodeling actually the lesion, not just kind of opening it up, but remodeling the plaque.
yeah. Yeah,
So I'm
that
going to
makes sense.
share some of my cases.
And I think what you said is correct about recoil showing is probably more prominent in this setting than in many others. Just because the other thing I think is also important what you mentioned about how with the type of pathology that we get in these lesions, you very often have to go to very high pressures, essentially ripping the vein, sort of a controlled, tear or rupture, if you will. I mean, it's rare to have extrav, but it's not unusual to really have to increase the pressure or use a high pressure balloon to do that. Anyway, yeah, tell
Yeah,
us.
so here's my first case. 75-year-old woman on HD via brachiocephalic fistula. She comes in with prolonged bleeding on HD. So what happens a lot in my practice, I create fistulas, and then patients, it works well, and then they disappear. They start going to other centers where they get stented. I am not a primary stent. I stent very selectively, but this woman went somewhere else, and her outflow veins been stented. And hopefully it projects well. But what you could see is, we obviously prolonged bleeding. We worry about outflow stenosis. And then so in the imaging, you see this high grade instant restenosis. So here, thinking this is probably going to be some really scarred in lesion. And that's what I chose to, instead of using high pressure balloons, is to use a Serenator. It looked like a big outflow vein, so I used 8x40 Serenator, one inflation based on IFU, and I think great result after just one inflation, no other
Yeah.
balloons. Um, so I think this is the great area for it because you know that in the stent you're gonna have like a scar tissue thickened plaque, really not something that's gonna open up with a regular PTA. Well, probably better with either high pressure or serration, and I think the serration has a good role here.
Yeah. That's a lot of stent in that outflow
Yeah,
vein.
yeah. And I think what I see a lot, so we know the bare metal stents. I don't know what stents these are. I hope they covered. I can't tell. But a lot of things, what happens in outpatient setting is that they get bare metal stents, and those stents really don't do well in dialysis access. Kidoku guidelines recommends to avoid bare metal stents, but I see it over and over again in my patients because that's what gets used in the outpatient setting because of the price and everything. But we're doing really a disservice when we stent so much, I think, and especially with bare metal stents. So the reintervention rate is very high in those patients.
Hmm. And tell me, it looked like that was a maybe even a stent overlap zone.
Yeah, it was. I think so.
Yeah.
Yeah, it was definitely a stent overlap that because they put, I think it looks like two stents, and that's the issue. What those overlaps is where you get really bad scar tissue.
Yeah. And just for since you brought up this the issue of stenting and covered stents, do you use covered stents very often and do you
If I
save those
stent, I
for
would
end
use covered
stage
stents.
or
So,
yeah,
if
okay.
I stent, I would use covered stent. My algorithm for stent, there's only one area where I believe in sort of primary stenting. It's the AV graft on venous anastomosis in the AV graft. I think there's a pretty convincing data that if you stent those, uh, the long-term patency is much better with a covered stent. There's some randomized control trials that show that stenting with covered stent AV graft anastomosis is what works the best. So that's really the only area where I consider stenting as a primary therapy, and I think that's consistent with what Kidoku recommends. But all the other areas, obviously, if you have extract that you can control, you'll stent to bail out. But primary stenting, I only believe in AV graft anastomosis.
Hmm.
Centrally, I really try to avoid it. I see a lot of patients with crushed central venous stents, which becomes a really problematic thing for me later on down the line.
Yeah, not much. Are you talking about at the thoracic
Yeah,
outlet or
thoracic outlet, but
yeah.
I see those all the time now. And I
Oh
think that's just
my.
a sign of getting like advanced dialysis access practices that people just send you like everybody that I want to manage anymore.
Yeah. But it's almost like we have to relearn certain things. I mean, stents do not do well of any flavor at that location. Not while there's a first rib in place anyway.
Yeah.
Um, yeah, so interesting case. Anything, Atish, on your end? Um, are you seeing a lot of this? Patients coming in with
Yeah, I
stents,
mean,
a lot of
I did.
stents in the central venous system, or
I do see him in the central venous, less in the, kind of first rib region, more nominate vein and subclavian vein, and I have a case of that. And then some in the cephalic arch. Have been better about avoiding the true subclavian vein and across the clavicle. And so thankfully those areas have been avoided pretty well. I actually I can count on my hand how many times I've stented. I really try to avoid it. And I've gotten away with it. I don't know. It's possible that some of these patients have gone somewhere else and gotten stented after the fact, but I do
right?
follow my patients increasingly. Um, it just sort of depends on who's referring to me. Some of the nephrologists will follow their own, and some won't. But increasingly, I've followed my own. One, so I know, and especially as I'm trying these new therapies, I kind of want to know, am I making a difference with them, and to track, whether my cost use it makes sense for these patients. And then the other cases is that sometimes the patients are referred back when it's too late, like 3 years down the road, and now their fistulas really basically failed, when I think we probably had an opportunity to intervene. So I do end up seeing a lot of them, and thankfully I think most of them have avoided some of the compromising stents, but they do get stented every once in a while for sure.
Hmm.
And they're
Okay.
almost always uncovered,
Hmm.
from what I've seen, and
Yeah.
I'm
Well,
sure
and I
that's
think
just the cost. Yeah.
that's distinctly different from the indication that Yana mentioned of
Yeah,
the
absolutely.
graft to vein anastomosis. I mean, that's a great place for a covered stent, in my
Yeah.
opinion. Yeah, absolutely. And the data for that is really good. Also, yeah, please, Yana, why don't you go ahead?
So, another patient that this is actually a non-maturing fistula, 79-year-old, and you'll tell me why I'm putting fistulas in such an old patient, but she was quite robust. Kind of, it seems like independent living. So, I do an individualized decision who gets grafts, who gets fistulas. She said she looked like she had a decent cephalic vein in the upper arm, so I created a brachiocephalic fistula, but in the like a month later, I looked at the ultrasound, looked like there was a high grade stenosis in one area. So this is the picture, just basically just above the justa anastomotic region, there was one focal area of pretty very tight stenosis with where that branches. So I decided to try to use um, Serenada, so 5 millimeter. I traditionally use either 5 or 6 in the non-maturing fistulas to start. I do believe not to do too many interventions. So my algorithm tried to get them matured with one intervention as possible. This was very tight stenosis, so I just went with 5, one inflation, and it looked really good. Afterwards, I decided to leave it at this, let it mature a little bit more on its own. But yeah, my algorithm not go above like 7 millimeter balloon to start, 6 to 7, and then see, but try to avoid more than one intervention on these and try to get them mature really with one. I think this was a good area to use this because it was like a focal stenosis, probably a valve, a Scardin valve, and with one ballooning, no extra or anything like that.
Hmm.
Because you worry about extra in these patients if you over balloon or use high pressure balloon on fresh fistulas. And then it creates another problem, hematomas, delaying access, things like that.
Yeah. Yeah, it makes sense. So in your in this case of a non-maturing fistula, you start out with ultrasound or duplex, you figure out where you think the lesion is. In this case, you went probably in the vein.
In
Um,
this case, I went in the vein. So my traditionally, I usually go into radial artery if I can. This patient, her Allen test was not normal, so radial dominant. So then I avoid radial access, but 80% of the time I use radial because it's easier. Here I went into the proximal fistula, and it was advantageous. Her proximal fistula was fine. Otherwise, I would had to go other way, sort of retrograde fistula.
yeah.
But my radial access is my approach, really preferred it as long as the Allen's test is good, but hers wasn't.
Okay. So you go radial access and a 6 French sheath,
Yeah, 6 French radial
typically.
sheath.
Yeah.
And the
How
nice thing
about,
about
yeah.
that sheet, it allows you to go up to like, well, regular balloon, you can go really high, and a lot of high pressure balloons go through 6 radial sheath. A lot of serenaded balloons go through 6 French radial sheath. So I think it's advantageous to just go 6 French.
Okay. Okay. Yeah, that sounds good. Atish, anything on your end, or do you use the radial, or how do
Yeah,
you typically approach it?
yeah, I use the radio selectively. We have a lot of Hispanic population and Laos patients and patients with pretty severe distal disease, and so it's not common that I have a good radial and ulnar, and so I have to be very selective because of that. I do think if you have that option, I think it's very advantageous, and you can really address the problem pretty easily from that approach. In one of my cases, I had to do that, um, specifically because the lesion was so tight, and that was kind of the only way I could get through. But typically, I access the fistula, sometimes antegrade and retrograde. It's a little bit more annoying, but it's just the safer option in my patient population, is what I've found.
I find
Okay.
that
Yeah.
when you do retrograde, your hands are always on the X-ray. I
Yeah.
haven't figured out a way to protect my hands, and it becomes very ergonomically not feasible. I really kind of hate that. So I really try to do radial if I can. And when I create radiocephalic fistulas, I go a little bit higher to give the space, like where I can cannulate the radial. I always call it plan for BAM when I create the fistulas. It doesn't have to be right at the wrist. It doesn't have to be snap box. We don't
Yeah.
have to, just just a little bit higher. Give yourself like an inch or so of the radial artery so you can stick it later.
Yeah.
Yeah. Interesting. Yeah, very good. Interesting. Good case.
Let me show you one last case of a different pathologist. So it's like a central venous stenosis. It's a 67-year-old guy with arm swelling and aneurysmal fistula, his brachiocephalic fistula. And you see two areas, cephalic arch stenosis and a subclavian vein, very tight stenosis. And again, decided to use an 8 millimeter because it's an subclavian vein. And so I used the same balloon in both areas with one inflation in both. And it looks pretty good. I know the cephalic arch still has some residual stenosis, but I try not to overinflate and I try not to stent. Symptoms resolve pretty fast. Is he gonna be back? They're all gonna be back. All the central venous stenosis patients recur, but I'm hoping that it's gonna be not like every month that I will have to reintervene.
Yeah, this is a really good result, especially in these particular areas are especially this phallic arch, but also I think that the vein just proximal to it is very often not you a lot of times don't get a very good
Mhm.
result from a treatment there. So yeah, it looks like Serenader was a good call here. Um, in this case, and this is one that, and you said you don't do surveillance routinely, but probably if they had some problem with flow rates or something, they would call you from
Yeah, I mean,
dialysis.
this guy comes in, he's just arm swelling, so and
Yeah,
the fistula is
okay.
aneurysmal. So once they tell it's aneurysmal, I know there's a problem. So I don't really need to get an ultrasound to know what the problem is.
Yeah. Yeah, that makes sense. I've got a couple of questions here from the chat. The one is on this idea about sizing of the serenader for fistula interventions. So do you go for a one-to-one sizing, or do you kind of use the serenader more as a like a pre-treatment and then go with a regular balloon? How do you like to do it?
I personally try less is more for me, so I try to stick to one balloon if I can. I don't think of it as a prep a balloon, right? I'm thinking of it as a treatment. So I look at what the vein is proximal and distal to the lesion and size to that one to one, and hope that one treatment will be enough. Because I think
Okay.
every time you reballoon, you traumatize the vein over and over again, and then you induce more trauma, which means more intimal hyperplasia.
Okay. That makes sense. And the way you just described it is the way I do it, and I also do it that way for above and below the knee as well. Although occasionally you need to pre-dilate, especially you have a long passage to an AT origin lesion and you're turning. Yeah, I might pre-dilate that, but otherwise, I typically go one-to-one with a serenader. That's just sort of what has worked well for me. I don't know, Atish, any difference on that or anything else you do that I should mention?
Yeah, no, I pretty much do one-to-one for fistula for the main body of the fistula, if you will. That I aim for 6 millimeters just as a standard, and then as I get closer to the venous arch or cephalic veins, I start upsizing a little bit more, just as what I would expect. So, in the cephalic arch, I try to aim for 7 or maybe even 8, depending on the size of the patient and the anatomy. And then, unfortunately for central venous, that might not be enough. And so, I have a case where I show where I have to use an additional balloon that's just larger than an 8, and there just wasn't an option. But in that case, I did use it to prep the vessel. I find that in those type of where it's supposed to really be, in the teens, that size of that vein, those you kind of have to gradually build up, or you risk them rupturing and in a really difficult spot. So for those specific lesions, which I think is a very different scenario, I think gradually increasing the size is beneficial, just to prevent a sort of a catastrophic rupture in a challenging area.
In
But
any
otherwise, I try
specific
to,
location that you're thinking of?
yeah, like the innominate vein, or
Yeah.
or even proximal subclavian vein. Those regions, if you
Yeah.
have a rupture, it's just a difficult
It's a bigger
salvage
deal.
situation.
Yeah.
Yeah. So to try to get up to the size, sometimes I use sequential ballooning, but otherwise
Yeah.
I try to limit the amount of balloons. Not only just cost, time is cost too for everybody too. So for a variety of reasons, I try to limit the amount of balloons. So 6 in the main body of the fistula, 7 or 8 in the arch, and then 8 more centrally and upsize as needed.
Yeah, that sounds good. It actually segues into another question about when somebody is a new user, they're starting out using this particular device. Are there any ideal areas for treatment or any areas that they should avoid, spots to avoid? Sounds like you hit one of them. Just be careful around the central veins. How about great places to start with one of these?
I think in stent stenosis, if it's size, so I think one of the limitations that the biggest size is 8. And in the fistula work, sometimes you just need bigger sizes for the central veins. But like I think in stent stenosis is pretty straightforward, right? Especially like cephalic arch, like I showed the first case. And even the new fistulas, I think too, because I think I have not seen any extra from these balloons. Um, so far. And like I've definitely seen a lot of extras of high pressure balloons when I use them in the fistula, but I have not seen extra. So I think it can be comfortable using them in pretty new fistulas as well.
Mm-hmm.
Yeah, I
Yeah.
think they're incredibly safe. I think you can use it pretty much anywhere. I would say the area where you risk the balloon itself potentially leaking is in a tortuous angle with a calcified lesion, which we're not seeing too much in this situation. But that's where I've seen those balloons could potentially leak, or cause an issue that way. But the vein itself, in generally, is fine. It would just be the balloon may leak
Yeah.
in a tight spot, in a tight angle. But I think it's safe to use pretty much anywhere.
Great. Okay. There's a bunch of questions here. I don't know if we'll get to all of them. Let me here's a really pretty straightforward one. How many cases did it take for you and your team to feel comfortable?
I would say 1 or 2. It's the triple prep, and so we've gotten used to that with some of the IVL systems. So as long as you know the triple prep, there really isn't much other than starting low and slow, and then taking it up a minute later, and increasing the atmospheres a little bit. But
Hmm.
you can feel safe to oversize and underinflate. That's what I like about this balloon. You can make sure you get maximal luminal contact without overinflating, so you can really oversize it if you want a little bit, and just underinflate it if you think your balloon is too big and it's in there, and you're safe, and you don't have to take it all the way to nominal. But I think just low and slow, and one or two cases, you'll be very comfortable with it. The main trick is as you're getting bigger in sizes with the balloons, to make sure you're doing short throws with your hand through the sheath, because otherwise you can kink your wire. It is a little bit bigger going through a sheath, and so you just initially, when you're going through the valves of the sheath, you want to do some short throws, and to get it through that initial resistance, and then you're fine after that.
Yeah, and
Makes
here I
sense.
think if you use prelude sheets, they're short, like the 6 French short radial sheets, they're really beneficial because you don't have hard time pushing it through. But I agree, like when you do PAD work and you have long sheets up and over, it's a little bit like harder just to get it through in the beginning, and it takes a case or two to get used to it. But in the fistula work, just use short sheets. It's really easy. And I don't think there's much learning curve to this balloon. It's just, balloon is a balloon. We all have skills to use balloons, and just follow the IFU, how you go up with the pressure, like you mentioned. And I think it's pretty straightforward.
Yeah, makes sense. Atish, you want to share your screen and show a
Yeah.
couple cases?
Sorry.
Very good.
Alrighty, so just I have four quick cases here, so when we can skip the last one if we're running low on time. But this
And
is,
then, are you in a presentation mode? It's coming across a little small.
oh, is it? Let me switch it. Is that better or no?
It's still maybe go on your lower right-hand corner where the lower right, where it can go full screen. You know,
Yeah.
perfect.
Is that coming up better? Okay.
Yeah, it's perfect. Looks
So
great.
the first case is a case where 60-year-old female had a left BC fistula created 5 years prior, and again, prolonged bleeding, poor dialysis clearance, and so was referred back to me. We did an ultrasound in the clinic and showed stenosis in the proximal segment. This patient also had a cephalic arch stent and developed in-stent restenosis. So on the initial fistulogram, we see two tight lesions, and you can see there that the initial one is very tapered, looks very fibrotic, and the second one is within the stent and an area of repetitive injury due to flow dynamics. And so you can tell these are going to be very fibroelastic lesions and going to be more resistant. So this is one where I would jump to use the Serenator early and not waste time and extra balloons and exchanges and just try to go for a definitive therapy. And so we saw a extremely tight waist. You can see there with a standard balloon initially, and then and the reason why we used a standard balloon initially is because we had actually a smaller sheath off the get-go. We had a 5 French sheath in, and I can't remember exactly why we did, but in any case, we sort of tried to pre-dilate it. It was very resistant. I think this was early on in my Serenator practice, and then jumped to, and we saw the recoil right after that. Um, and so then followed that up with a Serenator initially in this first part of the fistula, in the mid fistula, and then we didn't use in the cephalic arch yet, and then brought it back in and did in the cephalic arch. And you can just see kind of the progression and what a difference it made when we used the Serenator versus just a standard non-compliant balloon. Um, this was actually before we had the 7s and 8s, so this was a 6 mm Serenator. And then I did follow up because it was undersized at the 6. I did follow up with a 7 mm DCB in that arch stent. And that was primarily just because we didn't have the right size at that time.
Yeah,
Um,
looks good.
yeah,
Looks
so
really
patient
good.
did very well.
Yeah.
So
And
they're
how
18 months out now and haven't had to reintervene, and I've been following them since.
hmm. And what's your Atish, what's your DCB practice? Um, I know Yana doesn't use them a lot, but there have been a couple papers. There was the RCT in the New England Journal from Rob Lookstein and Andrew Holden that looked pretty good in terms of reduction in repeat interventions with DCB. Um, it does add cost, no question. And I don't know, what's your current thinking on that?
Yeah, I mean, I think for this one, primarily I used it because I needed to use a bigger size balloon anyway. It was in a stent, it was restenosis. Clearly, someone had been in there intervening, even though the patient couldn't tell me that in the past. And so, a recurrent stenosis with already within a stent and a failing fistula, I opted to use it. I typically use it on I don't use it de novo. I don't use it as initial treatment for initial native stenosis. But if they have a recurrent stenosis, have undergone multiple interventions, I try to use something different. And I've been following my patients for it. Anecdotally, I have noticed that I do get several months longer. I mean, these patients are measured in the months and not years on their access life. But as they become, as access becomes more tricky and fewer options, as in this patient, I try to employ the therapy to see if I can get a little bit extra durability and longevity out of the fistula.
Yeah, very good. Um, and that and also just from a just so that people can understand, um, kind of your current you and for Yana, your current approach to cephalic arch. I mean, it seems to be the weak link in the system for any otherwise robust upper extremity and especially brachiocephalic fistula. Um, when you get a cephalic arch stenosis, what's your first line of treatment typically?
Mine is starting with just straightforward balloon angioplasty. If it's a native vessel, then I will use a standard non-compliant balloon and see how it looks, and then follow it up with Serenator if needed. If it's a recurrent stenosis, then I'll more and more just jump straight to a Serenator and then follow it with a drug-coated balloon as well. But I really avoid stenting. Like I said, it's a handful of times I have stented, and it tends to be more at the venous anastomosis of arteriovenous grafts. I really try to avoid stenting, especially in this region, so I can preserve options. Sometimes if the cephalic arch is really a problem, I can convert that cephalic arch to a graft if I really need to, and they can get another axillary graft after that. So sometimes if you're stenting in that area, you're burning two additional options in that arm. And so I really don't like it personally. And so I try to balloon it at all costs if I can.
Yeah.
I think one of the things that's overlooked a lot is restricting flow. So a lot of these patients have fistulas that like 2, 3 liters flow over a liter, which you don't need. And the reason this the cephalic stenosis or stenosis in the subclavian vein. So I think that a lot of us have natural stenosis in the subclavian vein, right? And it's asymptomatic. But if you put a fistula in that arm that has 2 liters of flow, now it becomes a symptomatic issue. And I think what the right thing to do is to restrict flow, to bend the fistula, to have it less than a liter flow. But that's a procedure that's really overlooked. And a lot of times we just go into the pattern angioplasty stenting, right? And then it's too late to do anything else. And I think I'm sort of thinking that a tissue practice is very different from mine. I'm a little bit jealous that you're able to actually follow your patients for so long. My patients often disappear and get sent to another 15,000 dialysis access centers in New York City. And then by the time they come back, so many bridges been burned that I feel like there's not a right answer anymore. But if it was up to me, after 1 or 2 angioplasties, if it's still an issue, I would consider restriction flow and high flow fistulas.
Very good. I think you have maybe Atish one more case. Um,
Yeah, I have a couple more, but we can
yeah,
kind of
jump
this.
in. Yeah, we got a couple more questions, but why don't you let's see your case.
Yeah, so this is someone who's a louse patient with multiple prior AV accesses, had a very hostile arm, had a graft explantation 12 weeks ago. I'm not sure what they put in, but you could tell the skin was completely tethered and just a really hostile arm. They had severe steel syndrome, hand pain, ulceration of the finger, and the duplex showed probable clamp injury. And so we did
But we
an
don't see it
angiogram.
yet. We see
Oh,
the
it's not. It's not.
it didn't advance yet.
I see. Sorry.
There you
So,
go.
very tight at the anastomosis here, and it was the fistula had already been coiled, but you can see how tight the lesion was, and I actually couldn't get across it from this approach. I had to go radial and use a CTO wire to really get across it, and And this was in the brachial artery, but very resistant lesion. Initially, I had to actually use a 2.5 millimeter Cyrenator SL Pro in this region, and then followed it up with a 5 millimeter Cyrenator, and we had a pretty good result. Patient was moving from the significant hand pain and the steel, but pretty significantly improved result and durable 14 months out, and very old and frail lady. And so I just think that going into that hostile anatomy in the arm, I really think we would have done a lot more damage. She didn't have any good saphenous vein either for reconstruction. So we would have been splicing some arm veins from the other arm to reconstruct that. And so it was just kind of no good options, and came away with a reasonable result there.
Yeah, yeah,
She
wow.
healed her ulcer.
Artery looks good. I mean, basically CLTI of the upper extremity.
Yeah.
And what did she end up with for dialysis? Were you able to go to the other arm, or was she catheter based?
I did a taper graft in the other arm, and she did well with that.
Hmm. Okay, yeah,
Yeah.
interesting. And
I
then,
mean, the
one
other
of,
thing to
oh,
think here is avoid the arms. Looks like there's tiny arteries, right? Like the first, and
Yeah.
consider a chest wall AV graft. I think it's another procedure that underlooked for these patients with really small, especially women. They know that the subclavian or axillary artery and vein will be better. So I even have a problem like that. I'm thinking about chest wall AV grafts. Those last pretty long time.
yeah. And
Yeah.
Yana, when you do those, where do you go from where is it axillary to axillary or
Yeah, right. That incision that you do for X-Fem bypass is right under the clavicle, a
yeah,
looped X graft, like, on one side, and it works great.
great. Yeah. Here's let me get a couple questions in from the group here. One is for high pressure POBA, um, is that painful to the patient, and would low pressure Serenator provide better patient satisfaction? So, I mean, I know that when I put a balloon to high pressure, if the patient is not pretty well sedated, they definitely feel it. I guess I never really made the leap to, hey, wait a minute, this could be like a patient satisfaction issue as well. I've been more thinking about the result on the completion. What do you guys think? What have you noticed?
Yeah, I've certainly noticed it. I mean, you see it on May Thurner's patients, definitely, and then sometimes I see it on fistulas as well. Less so. I mean, I just use a lot less high pressure now, but and sometimes these patients are a little bit, it doesn't take a lot of sedation to really get them knocked out. They're just very frail and often exhausted at baseline. So, but occasionally on tight lesions, I definitely notice that the high pressure causes pain, and I see that more in the central venous stenosis.
Hmm.
So I do them basically awake. I don't have anesthesiologist for these procedures. I do my own sedation with a little bit of Versed and fentanyl. And I think all my patients have pain when I balloon, especially with high pressure. I mean, it's very common for them when you mature fistulas, when they're small. It almost like if they don't feel pressure, it's probably because your balloon is undersized. So if you can avoid high pressure balloons, I think it's definitely beneficial. Because if you don't have, I mean, I don't have anesthesiologists in my setting. I just do them awake.
Hmm. Hmm.
It's very it's very much an uncomfortable feeling if you're doing a central venous stenosis and they're feeling chest pressure and you don't know if it's their
Yeah.
heart or these sick
Right.
patients or what's going on. So
I
yeah, I
know.
mean,
And you think, okay, how
it's a very
deep is my
underrated thing.
wire? They
Yes,
start coughing. You go,
yes,
oh, what's happening?
yeah.
And
It's not a good
yeah,
feeling.
and
So
it's not so easy to get a high integrity venogram in that setting without quite a bit of contrast. So,
yes.
yep, I know exactly what you're talking about. Let me ask you one other one. This is a good question. If you aren't getting full vessel effacement, what would be your next step? Because we talked a lot about low pressure, et cetera, or not going to nominal if you have an oversized balloon, or I mean, you guys have mentioned several tips or tricks that you use. So, what do you do with full vessel effacement? You're not getting full vessel effacement.
So I will go above nominal first. I've never seen these balloons burst yet, so and the nominal pressure is not high, so uh because you go to like 2 and 4 and then 6, and that's supposed to be nominal, but that's pretty low pressure, right? So I would just first go to above nominal. I brought them up pretty high, 10 and more, right? And then if that doesn't work, then you just have to think about what's the next balloon. But most of the time, it's pretty safe to go above nominal.
Yeah, I would agree with you. And I would also say that once in a while, you don't get a perfect result, almost no matter what you're using. And so sometimes you settle for a much better lumen, even if it's not perfect. But anyways, and then let's do one more question, and then we'll have Atish will have you do a, speed dating version of your
Okay.
last case. How does that sound? And the question is, how many inflations on average do you typically need in these AV fistula cases? So how many inflations on average? So given a specific lesion, what do you think?
It's
With the
typically just
serenade, I
one.
think one,
Yeah. Yeah, typically one, unless it's going to be undersized or for whatever reason you're using another therapy, but usually just the one. If it's a really tight lesion in a precarious place, I'll use a couple. I'll use something to predilate, but typically just one.
Yeah.
It's unusual that I'm using another one.
Yeah. And also and the other thing I do from time to time is if I do that first one and kind of going back to that last question about I didn't get full vessel effacement, and I've gone to the pressure I want to go to, I might let it down, move it a little bit, rotate a little bit, and then go back up. So that would be a case where it's occasional, I'd say less than 10%, where I feel like I want to balloon it again. But I think that answers that. Why don't you? We got just a few minutes left. Why don't you show us one more case?
Yeah, I think this is one that just more underscores the patient standpoint. It's a 60-year-old male, cerebral palsy, multiple visits, has undergone 3 prior fistulograms in 2 to 3 month intervals at a referring center, all with POBA, and he had a high-grade stenosis, progressive aneurysmal fistula, and edema, and you just see a very tight lesion at the cephalic arch and a pretty good result. And this was a 6 millimeter actually. Also, it was 6 millimeter at the time, and a very reasonable result. And he's remained durable as far as he was followed up. I haven't thinking about it now. I haven't seen him in at least 6 months, but he's done very well since then
He's probably going to show up in Yana's office tomorrow.
with
So,
multiple stents.
yeah.
Yeah.
But now, oh yeah, go. That's a
I'll
great
skip to the
result, by the
last
way.
one, and then
Yeah.
so this is just another guy who's now undergone cephalic and subclavian vein stenting after BC fistula done, I guess, 6 years ago. These stents were placed 3 months ago, and he has decreased dialysis clearance, prolonged bleeding, and so we saw this really tight central venous stenosis lesions there, and you can see all the stenting that was done there. And so I initially I had ballooned that with a 5 millimeter non-compliant balloon, and this is one where I used multiple inflation. I used an 8 millimeter balloon, and you can still see it's quite undersized for that region. We had it didn't look like it fully. It looked like we had some recoil there, and that's just because the balloon was undersized. And so in this case, I followed it up with a 14 Atlas, very tight lesion. You can see the waist there. But because I think it released some of the fibrotic tissue, it opened up nicely, and I didn't have to go too high pressure with an Atlas, again, in a very sort of challenging location where you wouldn't want something like extravasation to happen. And so I think this was an area where even though the balloon was 8 millimeter and undersized, I think it did release some of the fibers, which allowed me to make gradual progression on a very tight lesion and get a nice result in the end. And so I think this just sort of highlights sometimes you do need a couple of balloons, but this is the rare case where you do need that.
Yeah, that's a really interesting case. I would say vein map the right arm.
I was
Uh,
about to say that plan for
but
the other side, plan for something
yeah,
else. This is not gonna last.
Well, that stent goes all the way down into
Yeah.
the
Yeah,
SVC there,
but you got a
so
good
the
result there
right
for
side's
now.
already kind of someone's compromised that side too.
Yeah. But in any event, I mean, the saga continues. This is not an easy area to practice. Luckily, the patients really appreciate it if you can do something for
Yeah.
them that lasts at all. So, and lots of people stayed on. We have dozens of people on, even though it's getting late. And especially Yana, thanks for a wild evening here. It's already 9 p.m. there on the East Coast, so thank you for that. And we answered a lot of good questions. Saw 7 cases. That was terrific. So thank you to Atish and to Yana, and thanks to the Cajun folks for sponsoring. So hope you
You're
have a
welcome.
nice evening.
Thanks very much, Peter.
And all right, talk
Have a good
soon.
night. Bye-bye.